you may not be used to working around all of that equipment. And when we have all of that equipment, it's really easy to get distracted and focus on the machines instead of the human being, our patient, who's laying in the bed. So it's important to know the machines, realize they're going to make a lot of alarms, but don't forget that that patient is lying in the bed, frightened. They've heard the news. They know what their prognosis is. They know they may not leave. And now they don't have any family members to be able to visit with them either. So talk to your patient. They can hear you even if they can't respond to you. Introduce yourself. Explain what you're doing. Reassure them. Hold their hand and use therapeutic touch whenever possible. It's important for these patients to know that you're there and that they're not inside, not being able to respond, wondering what's going on around them. So what else do I need at the bedside in caring for a patient with a ventilator? Well, when you're managing a patient with a ventilator, there's a lot of suction equipment that you need. I told you about the subglottic suction on the endotracheal tube earlier, but you'll also need suction for inline suctioning the endotracheal tube, and that's a separate suction setup. So each one of these is a separate suction setup. You need inline suction, you need subglottic suction, you'll need oral secretion suction, that's a different suction line, and if your patient has a nasogastric tube hooked to suction, you'll need a suction for that. So you could potentially need 4 suction tubings. The nasogastric tube should go to its own canister. But the oral suction secretions and the one for inline suction can use 2 different suction tubings, as you see in this photo on the slide. And I'd like to thank my colleagues Brandy and Amber for providing that photo. It was very helpful to be able to demonstrate it. But you can see that the suction canister has an adapter which allows 2 suction tubings to be attached to it. And those are the suction that goes to the inline endotracheal tube suctioning, which I'll be showing you later. And the other suction tubing goes to the oral secretion suction line. Again, very important that they are not together, that they go into the same canister, but that they go to separate suction tubings. And then the subglottic suction will go to its own as well. The other responsibility that you'll have is to ensure that that suction setup is functioning. And remember that the subglottic suction needs to be on a low continuous and always on. What else do I need at the bedside? Well, there's a lot in the literature right now about bag valve masks and patients with COVID-19. That bag valve mask needs to have either a HEPA filter or a high-quality HME, which is a heat moisture exchanging filter, between the face mask and the reservoir bag in order to help reduce the risk of aerosolization and that viral load being sprayed out into the room. When a patient gets intubated, the mask gets taken off of the bag valve, and it needs to be retained, perhaps in a plastic bag hanging at the bedside, but don't lose the mask. The mask has to be available in case a patient extubates themselves, and I'll talk more about that later. The bag valve mask should also be ready to be connected to oxygen, and so it needs to have its tubing on it, and you want to ensure that the oxygen is functional. The other thing you'll need at the bedside is your oral care kits, and those oral care kits should be chlorhexidine rinse, preferably a prepackaged kit, which makes it easier to do the oral care. But if it's not available, at least having the chlorhexidine rinse available is very important. And we'll talk more about oral care in just a few minutes. The other thing I want you to know that you can expect is that you may see the ventilator inside the room, but the ventilator console may be outside of the room. And in the usual ventilators that the ICUs usually use, that is possible to do, that you can actually remove the console, as you see in the right side of your screen, and put it outside the room, along with the IV pumps. Nurses are innovative and creative, and we've gotten really innovative and creative about making it easier to limit the number of times a nurse has to go into a patient room. And so in this way, you can monitor the ventilator from outside of the room, and the respiratory therapist can make the changes from outside of the room as well. Other things that are different for a patient on a ventilator, including assessing pain and sedation. And you're used to assessing pain, but you may not be used to assessing sedation. So let me go over this a little bit for you. Your pain assessment, you'll want to check with your hospital about what scales or tools you're using. But you might be using something as simple as a visual analog scale, the 1 to 10 scale, where the patient just gives you a number like you're used to doing. But in patients who are unresponsive or can't respond, you'll be probably using one of these two tools, a critical care pain observation tool or a behavioral pain score. And you can have your ICU nurse go over that a bit with you, but I'm also going to give you a resource for it in just a minute. Sedation is important to assess because these patients are on pain medication or analgesia as well as sedatives. And the two most commonly used scores are the Richmond Agitation Sedation Scale and the Sedation Assessment Scale. And those scores look at how much your patient is agitated or how much they're sedated. Now, have you heard about patients being on neuromuscular blockade? Some of these patients, because of their inability to tolerate the ventilator giving them breaths, may have to be paralyzed with pharmacologic paralysis. And so that's called neuromuscular blockade. If you have a patient who's on a neuromuscular blocker, they can't respond to you, so you can't assess their sedation levels, nor can you assess their pain levels. So there is a way to assess sedation using a bispectral analysis, which is a one-lead EEG. And it gives a numeric readout, and the number that you're most commonly going to use is somewhere between 40 to 60, which means the patient has amnesia. The higher it is, the more alert they are. The lower it is, the closer they are to anesthesia. So somewhere between 40 to 60 is usually the number with the bispectral analysis. But hopefully you won't be managing any patients on neuromuscular blockers. And I'll talk a little bit more about neuromuscular blockers in just a minute. AACN has provided an open access journal article that does have CE with it called Implementing the ABCDE Bundle, the Critical Care Pain Observation Tool, and the Richmond Agitation Sedation Scale to Reduce Ventilator Time. And it's available for free at that link. Pain and sedation is very important, and I want to emphasize this really clearly, is that you will always treat pain before administering sedation. It's called Anglo-sedation, is that the point is to provide analgesia before providing sedatives. Because what we've learned over time is that the patients who are demonstrating the most common cause of agitation is hypoxia, and the next common cause of agitation is pain. So it's very important to treat a patient who may be showing signs of agitation, check their oxygen, and then treat their pain first. Common medications that you'll expect to administer might include fentanyl and morphine. Morphine you want to use with caution because it can cause hypotension and bradydysrhythmias. You may also see IV acetaminophen used, and in some cases you may want to avoid NSAIDs because in patients with COVID-19, there have been studies showing a higher risk for acute kidney injury with concomitant use of an NSAID. So treat pain first. If the pain is managed for the patient and they're still needing something for sedation to help them tolerate the ventilator a little bit better, you can use one of the following interventions. These are usually ordered. Dexmedetomidine infusions. The beautiful thing about dexmedetomidine, also commonly known as Precedex, is that that drug does not cause respiratory depression. And because it doesn't cause respiratory depression, it can be used on patients who are also not on ventilators. So you may see it used on a patient on a ventilator, but it can also be used on a patient who is not on a ventilator. Midazolam can be administered either intermittently or as an infusion. And then another common sedation agent is propofol. Now, propofol infusions must only be administered to a patient who is receiving ventilatory support, who has a rate and volume ordered for it, so that they actually are breathing with the ventilator. Propofol is also a lipid, and one of the concerns with propofol is that the insert pages that you read requires that propofol tubing be changed every 12 hours. And when we're trying to limit the amount of times that a nurse goes in and out of a room with a patient who has COVID-19, that may not be realistic. So just be aware that the tubing on propofol has to be changed every 12 hours in order to reduce the risk of a secondary infection. So I'm taking care of this patient. They have ARDS, and they're on a neuromuscular blocker. They're not tolerating the ventilator, and they just needed to be paralyzed. Well, the main thing to remember is that these patients can hear, they can feel touch, and they can feel pain. And so you want to be very careful with these patients because they're lying there looking very calm and very genteel. They look like they're asleep, but they may not be. These patients absolutely need to be receiving analgesia plus sedation. They must also have passive range of motion and position changes as tolerated to prevent contractures and pressure injuries. If they are not in a prone position, and I'll talk more about prone positioning in just a minute, their head of bed should be at least 30 degrees to help reduce the risk of aspiration. If they are in the prone position, I'm seeing people are putting them in reverse Trendelenburg to keep their heads of bed elevated to prevent aspiration. A patient who's on a neuromuscular blocker also needs eye lubricant to protect the cornea due to a loss of the blink and an inability to close their eyes. And you may see these patients with their eyes taped shut using paper tape to protect the eyes. A patient on neuromuscular blockers also needs to have their level of neuromuscular blockade assessed using a peripheral nerve stimulator, commonly with the strategy of a train of 4 impulse delivery. I'm going to ask you to defer that assessment to your ICU RNs. It's certainly a skill you can learn. It does take some time to perfect it, and it would probably just be best for that one to be left to the ICU nurses at this time. If you want to learn it, please talk to your ICU nurses so that you can help us with that assessment, and they can teach it to you. For a patient ventilator, you're also going to help prevent ventilator-associated events. And oral care is one of our main strategies to prevent ventilator-associated pneumonia. You want to follow your hospital protocols for the equipment and frequency, but generally it's done at least every 4 hours, often as every 2, but every 4 is very common. You'll be using a chlorhexidine mouthwash with toothbrushing and oral moisturizer. The pink toothpaste sponges and oral glycerin swabs are not adequate oral care for a patient who is on a ventilator. They must have a chlorhexidine rinse to help prevent ventilator-associated pneumonia. I mentioned earlier in the assessment portion the pressure injuries that can occur due to the endotracheal tube and the ventilator, so be sure to always assess around the ET tube, the securement devices, and the ventilator tubing for where it may be laying across to help prevent any pressure injuries. Pneumothorax earlier as well. The pressure needed to ventilate these patients with ARDS puts them at a higher risk for barotrauma and pneumothorax. So when you're auscultating their lungs, and if you hear diminished breath sounds on one side, or perhaps absent breath sounds on one side, be sure to report that, because it could mean the patient's developed a pneumothorax. And then I mentioned the prevention of ventilator-associated pneumonia with oral care. Positioning also helps with that, so these patients will require repositioning at regular intervals. So what are the positions we should use for that patient with ARDS? Well, I want you to realize that you'll do your regular positioning that you would do with any patient to prevent pressure injuries. But with patients who have ARDS, you can expect prone positioning to be implemented if a patient has a PaO2 to FiO2 ratio of less than 150. Now, you're probably thinking, what is that? Well, the PaO2 you get off of a blood gas, and the FiO2 is the oxygen being delivered by the ventilator. So it's just, you divide it, PaO2 divided by FiO2. Normally, it's about 380. The lower it gets, the worse the patient's ARDS is. Simple as that. And a PaO2 of less than 150 is pretty bad. It's really close to severe ARDS. Prone positioning, done usually for up to 16 hours a day, helps improve oxygenation by shifting the blood flow in the lungs. If you can remember back to your anatomy and physiology, the alveolar capillary membrane is very thin. And what happens is the blood flow is dependent. So if you're laying supine, your patient, and they're laying supine, you're going to have edema flow to the back of the lungs. The heart is also heavy, and it sits between the lungs, but it can rest on the lungs. By putting the patient prone, you shift the dependent edema, and you also help relieve the heart's pressure from lying on the lungs. So that's a really great thing to do for patients who have severe or almost severe ARDS, and you will probably be seeing this. I'm reading a lot about it in the literature, and the nurses that I'm talking to are telling me that they're doing it very frequently for these patients with COVID-19. AACN is providing you some free resources for prone positioning. There's a webinar available, Why Prone, Why Now, Improving ARDS Outcomes for ARDS Patients, and it's available at the link that's on this slide. And then we have a video that was given to AACN by Cedars-Sinai. They demonstrated how to do the prone turn, how to position a patient prone in their simulation lab. And that video will be posted this week to AACN's COVID-19 resource page at the link provided. If you are asked to help with a patient, put them in a prone position, you're going to have some things you have to do before you do it. And it is a team event. It takes 4 to 6 to 8 people to do this. So just be aware of it. But the patient needs to be pre-oxygenated as much as possible. If they're being fed, you should probably stop the feedings during the position change and empty the stomach so that there's less of a risk of them vomiting and aspirating. You're also going to want to make sure you suction out their oral cavity and the endotracheal tube. The ECG leads will be removed from the front, and once you get them repositioned, they'll be replaced on the back. You're going to secure the endotracheal tube and lines and make sure that they're very safe so they don't get pulled out. And you'll be positioning tubes inserted above the waist to the top of the bed. Those below the waist will get positioned at the foot of the bed, except for chest tubes. If the patient has any other kind of drainage bags, like an ileostomy or colostomy, you'll want to empty those before the turn. And the other thing the team needs to is what's the exit strategy if the patient destabilizes while you're doing the turn or once you get them into the turn? How do you get them out of the turn quickly? And then once you have them prone, you'll want to consider using some 5-layer silicone dressings for high pressure or shear areas, such as the forehead, the nose, the chest, and the knees.